So I've been invited here to share with you an example of how we implemented one of the NICE guidelines, CG 177, into our practice. So my name is Emma. I'm a physio assistant practitioner within the IPOP service based at Samuel Johnson Hospital in Lichfield in Staffordshire. And I've worked in the role for about 15 years. So who are we? So the IPOP service is based over 2 sites and covers Lichfield, Burntwood and Tamworth, and is based in Staffordshire. We serve a population of approximately 180,000 people. As a service, we see approximately 10,000 referrals per year, and as part of our service provision, each patient is provided with a description of their condition and its implications, and will receive self-management training and support which empowers the patient to manage their condition and remain as independent as possible. We take referrals from GPs, consultants and advanced nurse practitioners for varying MSK conditions. We don't yet have the facility for self-referral. So the IPOPS team is made up of assistants, assistant practitioners, physios, extended scope practitioners and GPs with special interests, supported by an absolutely fabulous admin team. We were originally part of Staffordshire and Stoke-on-Trent Partnership, but we have recently been taken over by the Midlands Partnership NHS Trust. So let me take you back to 2011. IPOPs were running a lower limb class for patients with osteoarthritis in their knees or hips. This comprised of 10 exercises being completed for 3 minutes each in a circuit style for 6 weeks, with patients attending once a week. As a service, we decided to collate the outcomes of these classes for 2 years, and in 2014, we'd submitted our data to the local audit department. Later on in 2014, we received a copy of the audit, and it showed us some really interesting outcomes which we wanted to act on and help promote good practice. The opportunity then presented itself to reform the group with the release of the NICE clinical guidelines CG 177. So in 2015, a steering group comprising of 3 physios and 3 assistants, including myself, was formed to act upon audit data and patient and clinician feedback to analyse and ensure that current practice was aligned with these guidelines, whilst providing a cost-effective and efficient pathway that met the CCG targets. And this is where our osteoarthritis, self-management and independent living support group, or as it's more affectionately known, OASIS, was born. So what were OASIS's aims and objections? Well, these were not really apparent from the outset. They seem to have developed with time and longevity. However, the main aim was, and still is to try and implement the NICE guidelines with what we already had set up, and how we could ensure that we maintained a high-quality service that offers personalised, patient-centred care, but was evidence-based. We looked at what exercise could be used to structure the group around, as this was the main core treatment from the guidelines and would form the nucleus of OASIS. The education component posed many questions. What did we need to educate the people on? How would we deliver it? How would we make it understandable for our patients? What formats could we use? Written, verbal, taking into account individuals' learning styles. We also needed to keep it cost effective. We wanted the existing staff members to be key in running these groups. They already knew what the pitfalls were and what worked well. By using this cohort of staff, we felt that we wouldn't need any further training or development to allow this project to run. And ultimately, we wanted our patients to feel empowered to be self-managing their condition with confidence. So there were 4 main areas that we've highlighted as barriers and the potential solutions to implementing the guidelines into OASIS. This is not an exhaustive list, but those we felt had the biggest impact on the project and could have and have changed the course of it. These 4 areas were pain relief, exercise, weight management, and patient buy-in. So within CG 177, there was no updated information since 2008 with advice on pain relief and pharmaceutical management. So we have continued to use the GP to help, guide, and facilitate the patient with their pain relief. We've found that if patients feel that their current pain levels are managed, they would be more likely to partake in the exercise. But long waits to see the GP or healthcare profession seems to be a barrier for patients accessing this part of their care. Also, patients who do not feel that the pain relief in isolation has been successful, or the cohort of patients that don't like to take tablets, don't always want to go back for a review with the GP, and therefore tend to end up turning up at our department with having taken no regular pain relief. Within IPOPS, we now have a non-medical prescriber who we can turn to for additional support, and we can try and educate the patient about the benefits of taking some form of pain relief to facilitate the rehabilitation. We can advise on TENS use as an adjunct to core treatments for pain relief, and we have also the facility to be able to offer intra-articular corticosteroid injections, again as an adjunct to core treatments. We are very fortunate that within our service we can offer these adjuncts and medication reviews to help our patients manage their pain, making it more of an efficient pathway. When new guidelines are released, we will be looking at these and ensuring that the pathways and interventions stay current. Exercise. So this was and still is our biggest component we've found to implement. It's the core treatment as recommended in the guidelines. Yet there was no advice on any specific exercises we should be getting our patients to undertake. So we did various plan, do, study and act exercises to try out various exercise circuits, and patient feedback was always sought. At one point, we thought about a functional style continuous circuit that incorporated some exercises such as sit to stand and step-ups, but with simulated exercises such as getting in and out of a bed, up and out of the car, and carrying shopping. However, patient feedback strongly favoured a return to the 10-station exercise circuit as previously used, as they felt that it challenged them more and had greater benefits. So with a bit of tweaking to the stations, we've settled on an exercise circuit which included local muscle strengthening and general aerobic exercise. We felt as a service that we needed to be able to offer patients a safe place to exercise, somewhere that they could gain confidence in exercising and hopefully would feel motivated and empowered to be able to self-manage and continue to exercise once their sessions came to an end. So as well as exercise, weight management was recommended as a core treatment to those overweight or obese. On starting Oasis in 2015, we as a trust had a weight management service that we were able to refer our patients into for ongoing support, and this could run alongside Oasis. However, this service has got decommissioned, and as to date, we still have nowhere to signpost these patients to, apart from the GP, or to suggest self-funded weight management schemes such as Weight Watchers or Slimming World. Further discussions were had, and the idea of should we be weighing our patients and recording this as part of the project, but as a service, do we really have the skills and facilities to do this properly and offer the correct advice and support? We have devised a fact sheet as part of the education component that Oasis offers, covering various topics that are delivered throughout the programme. This fact sheet gives basic weight management advice, so in a small way we are trying to support our patients, but further support and funding is needed to help deliver this important part of the guidelines. So patient buy-in. It doesn't matter how good we think the service is that we are offering, without our patient motivation, commitment and buy-in, it will not help or change. As physios, we know the biggest challenge is to get our patients to undertake regular exercise and make lifestyle changes. To help this, we offered Oasis on 2 sites using different start times and days of the week. We introduced an induction session where we met the patients on a one-to-one basis, collated data and outcome measures, and gave them the opportunity to ask any questions or queries that they have. And we also used our own data to show those patients who attended 6 sessions versus 5 or less did much better overall, and outcomes were massively improved. We got our patients involved and asked them to contribute and write up their own experiences of using the service, and have patient story folders printed up into our waiting rooms. Who better for our patients to hear about the service than our other fellow service users? So what did and didn't work? Using frontline staff was a real plus for us. The staff know the ups and downs, the pitfalls, they understand what the patients are telling them, and they can use this knowledge to help align the guidelines and the service together. Completing regular PDSAs, these were used to trial out various ideas like exercises, the handouts, fact sheets, and even the music that was played during these sessions. They allowed us to see what worked and what didn't. We have had no additional funding. This whole project has been done in staff CPD time and in some clinic time. It has been slow progress. It has taken us 3 years to get to this stage, but don't be put off by this. It's been a continual learning experience. Things take time to develop. Early setup time is consuming and hard work, and you will need to be supported. We have been contacted by other physio services in the Trust who wanted to adopt our model. We have been happy to share this and will continue to do so. This is now the main treatment for OA in our service. This model is now used to treat all patients with OA knees and hips. We can offer one-to-one treatments for those patients who fall outside the pathway or for those unable to access OASIS for various reasons. We have also started working with local universities. Kiel have used the model as a regional example of excellence in regard to treating OA, and it has been used to help shape part of our STP. So these were our five keys to implementation. Timing and location. We need to offer variety to allow access for patients. Stable staffing. The same face for consistency in running and delivering OASIS has been invaluable. Data collection. It helps us to review and monitor outcomes to ensure we keep best quality. Having a clear pathway ensures that suitable patients are being encouraged to undertake OASIS. Also, a clear referral pathway streamlines management of these patients. And support. Give the staff time to develop the idea. Allow them time to read the evidence, to learn and implement changes. It's an ever-evolving process. We are continuing with collecting our data. We have now 3 years of data, and we are now looking at collecting prospective data to see how our patients who first undertook OASIS are progressing with their self-management plans. We are actively sharing the OASIS model. We have been invited to work with local universities and help shape their STPs. Also, physio departments in the UK and Ireland have also approached us about adopting the model, and we're more than happy to share our experiences. So one of my final thoughts I would like to leave with you today is just do it. Act on a good idea. Use the guidelines to help shape your model. Use the experience of your patients to help you develop the best service possible. And don't be afraid to showcase your work. You never know what journey can start from a simple idea. Take the first step and see where it leads. I would just like to thank all these people for their support in OASIS. Thank you.